What we'll be doing on this tape is going through the computer-based case simulations, which I'll refer to as the CCS. And obviously you folks are taking this test. This is a new format that you have not seen in Step 1 and Step 2. And it can induce quite a bit of anxiety and fear. And we're going to give you the advantage, if you've taken this course, at having been given a guideline to get through this format and some strategies to get through this format. And if you think about it in an organized fashion, you're going to find that there are a number of steps that you could take in each case that will make it very straightforward. All right? Now, an overview. You're going to have approximately 9 cases. This is going to be 1/2 of the 2 days that you take Step 3. There's going to be a maximum of 20 or 25 minutes of, quote, real time to manage each of these cases. Now, by real time, I'm talking about the time on your watch that you are living by in the real world. And as we go through this tape, I'll refer to case time and real time. Real time means the real world time of 20 or 25 minutes that you have to get through this case, get all the information you need, order all the tests you need, do the appropriate management, and get the appropriate follow-up in before you have to exit the case. And they will give you a prompt about how much real time you have left. When you're down to 5 minutes of real time, you will be told that, and at that point, you really have a limited set of options that we'll go through as we go through this tape now. I'll also refer to case time, meaning the amount of time that it takes to get a test back, or the amount of time it takes to see that your therapy works. And a test question can last over 20 minutes of case time. If you have a very acute patient, and you either get the patient better or you execute the patient, it might end very quickly. Or a case may take place over 6 months. If it's a chronic problem and you see the patient every 2 or 3 months, you might need to see 2 or 3 visits that take place over 6 months. And again, this is case time. Remember, most of what you're going to be tested on for the CCS is the management of the patient. We're going to assume that the diagnosis is relatively straightforward. By the time you finish reading the HPI, you should have a very good idea of what the diagnosis is. And if you're not sure exactly what the diagnosis is for sure, you should have a very short differential diagnostic list, and then your job will be to order the right test to further limit that differential diagnosis. Now, the reason this invokes so much anxiety because in the first time of your test-taking history, you're not given a set of choices to choose from. This is not 1 through 5. It's not A through M. You are on your own, and the world, the entire universe, is possible in terms of where to go next. And it sounds very terrifying, but think about what you have to do as your residency unfolds. Most of you are in or about to start your internship. And when the patient presents short of breath, they don't hand you a list of, these are the 5 things I think you should consider in managing my shortness of breath. You have to look at the patient, you make a differential diagnosis, and if you stop and think about it, this is the sort of stuff that you guys are doing automatically every day of the week, and it should not be that anxiety-provoking. All right? But again, in real life, we often do 3 or 4 things at once. We're asking the nurse to get us something, we're putting an IV in here, a nasogastric tube in there, starting a medication. You have to think about what is the most essential first thing to do. Because something as simple as putting in an IV, which you might be doing as you're taking a history in some patients, won't happen unless you order it. Nothing happens on the test unless you tell the computer to do it. Okay? And in real life, whatever you want done happens. All right? In real life, you might ask for 100 things and only 2 things get done. For better or worse, when you order something on this exam, you're going to get it done. Okay? Essentially, again, you have to prioritize, and each step, after each order is made, you have to say, what is the next step in the management of this patient? Now, let's talk about how to actually get through a case, screen by screen. And by screen, I mean exactly what you're going to see on your computer when you're taking the test. You're only getting 1 screen at a time, and the beginning of each case is essentially the same in terms of the format for every patient you're going to see on the CCS. What you're going to start each question with is the case introduction, which is essentially a chief complaint and consists of 1 or 2 sentences. And at that point, it's usually not possible nor should you try to make a very short differential diagnostic list. Because if you're stopping to think of differentials at that point, you don't have enough information to narrow down your list. And your list of possibilities is going to be far too broad. This is just introducing essentially what the chief complaint is, the age of the patient, where the patient is, what day it is. All right? Now remember, the patient may or may not be in the appropriate place. The patient may be walking into your office and might be exsanguinating from a GI hemorrhage. The patient may present to your office with a dissecting aortic aneurysm. And we'll talk in a few minutes about what to do with that patient when they're in a place you think they should not be and how to move that patient. Okay? The first screen will be the case introduction, again a sentence or two. Then nothing moves. The screen doesn't move. Real time is ticking away. You read that first sentence, you hit the next screen, and what are you going to get is the vital signs. The vital signs here is an extremely important screen in terms of how you're going to think about the rest of this case. When you look at the vital signs, and we're going to go through a screen of sample vital signs, and we're going to actually go through an entire case from beginning to end that we've manufactured for a review. You looking at the vital signs, this is when you should say to yourself, is this a stable patient or is this an unstable patient? Is this a patient who I could take some time figuring out the differential diagnosis, or is this a patient that as soon as possible, this emergency acute patient, do I have to start doing stuff to the patient? Maybe even before the physical exam. All right? You may or may not be able to tell that from the first sentence, from the chief complaint. Very often you will. Someone comes in extremely short of breath, holding his left side of his chest. You know that's probably an unstable patient in which you're going to have to act very acutely. On the other hand, if there was a case, again, these are cases you should have done already, or if you haven't done, you should get to the CD-ROM that the USMLE releases. Look at these cases. They've had a patient who had several weeks of diarrhea, or at least several days. That's unlikely to be an emergency case that you need to do something right away. All right? You should consciously ask yourself, is this a patient that I need to act on emergently? And that will obviously influence how you're going to manage that patient. So you're going to get the case introduction and the vital signs. That's screens 1 and 2. Again, you can't start giving any orders yet. You hit the next screen button, and the next thing that comes up is the initial history. Okay? And again, between screens 1, 2, and 3, there's no way to start ordering things and managing the patient. All right? Think of it as, in a sense, getting free information without having to think about what choices you need to make. Chief complaint, vital signs. At this point, you should have a very good idea if this is a stable or unstable patient. Now you get the history of present illness. If it's a long history of present illness, and the history of present illness screen is often multiple screens in the sense that you have to scroll down, and you need to learn how to use the scroll button, all right, because it's not going to forward to the next screen. You might have an HPI that fills up a whole screen, and then you'll start scrolling down, and you'll get past medical history, past surgical history, review of systems, allergies, family history, social history. That's all included for free, so to speak, in the HPI, history of present illness. Now, if you say to yourself, wait a second, I know this is a very unstable patient. This is a hypotensive patient. I need to get an IV line into this patient. I need to do lots of things for this patient. You can't take a shortcut out of the HPI. You can't say, listen, guys, you're giving me too much history. I don't care about your past medical history from 40 years ago. I don't care why your grandparents died. I want to start putting an IV into you. You can't do that. But that's to your benefit. You have, at this point, the ability to get all the information in, as much information as they're going to give you. You can't say, I'm so nervous, I got to start treating this patient. Be patient. The next screen, you'll have plenty of time to start treating this patient. Okay? Now, by the time you finish the HPI, probably by the time you finish that, literally the HPI, the history of present illness, before you get on to the past medical history, surgical history, etc., which is also part of that same screen, so to speak, you should have a very tight differential diagnosis. All right? What I mean, a tight 2, 3 possibilities in your differential diagnosis. And you should be, at that point, have a good hunch about what your number 1 differential diagnosis is. Okay? And very often, at that point, you'll be absolutely certain what the diagnosis is. And if there's nothing introduced later on, you don't have to change your diagnosis. Okay? It's appropriate. In real life, 90% of the diagnoses we make are made by the history. All right? Also look through the past medical history, past surgical history, allergies. Remember, you're going to start giving the patient medications. You're going to lose big points if you're giving the patient a medication that they're allergic to. Okay? And even if you give the patient a medication and they get better and don't have an allergic reaction, you could be sure the computer will remember that you gave the patient a medication that they're allergic to. So pay attention to all the information on that screen. I would, on your, what they call the scratch board, where they give you a marker and a board on which to write notes, as you're going through the HPI, jot down the pertinent positives and pertinent negatives. Someone on the CD-ROM had diarrhea. They had gone camping. Camping and diarrhea certainly is something I think is pertinent. If they tell me he has not traveled, no travel. If they've been on antibiotics, pertinent positive. Family history of 2 relatives with chronic inflammatory bowel disease, that's pertinent. Okay? You'll have the ability to go back and read the HPI again, but it's going to cost you time, real time. Okay? And again, if you got all the information right the first time from the HPI, you'll probably be able to make a diagnosis right then and there. Okay? Now, after you finish that HPI screen, you've written down the pertinent positives and negatives, you should, at that point, even write down on your scratch board what your differential diagnosis is. And again, if you got 5 or 6 or 7 things, you're thinking too much. It should not be that elusive a diagnosis. All right? Now, at this point, after you've read the history, the HPI, and all that supplementary information, this is when the test really begins for you. This is when you have to start making choices. Do not automatically assume that you do a history. Next step is automatically a physical. Because after the HPI screen, that's when you are given the option to press one of the 4 buttons on the top of your screen to do something. Very often, it'll be a physical exam. But not always. If you have a patient who they tell you was brought in by the ambulance after having a massive episode of hematemesis, and the patient comes in unconscious, and the history is given to you by a family member, are you going to start doing a physical examination of that patient who's hypotensive, in shock, you know has an upper GI bleed, before you put in an IV? No. Okay? Remember, if it's an unstable patient, and you'll know that from the chief complaint and the vital signs, the first thing that you need to do might be to stabilize the patient, even before the physical exam, because seconds are ticking by, minutes are ticking by, and remember, the failure to do things is also going to cost you points. Not only choosing the wrong thing, but the failure to do the right thing can cost you points. So if you have an unstable patient, a GI bleeder, you're getting the history, before you press get physical, I'm going to order an IV, and I'll order IV fluids. A patient who's coming in extremely short of breath and is cyanotic, put the patient on oxygen, start an IV. A patient with crushing substernal chest pain, hypotensive, is gasping for air, IV, oxygen, EKG monitor. What can I not afford to miss? An MI, I can't afford to miss ventricular tachycardia, VFib. Might happen in the 10 seconds while I'm starting to take a physical. So remember, after the HPI, that's why you should have already said to yourself, stable or unstable. If it's unstable, do what you have to do to stabilize the patient. And think about it. Do you think you could lose a lot of points for putting in an IV early before you do a physical? No. All right? So say to yourself, is this unstable? If the patient is unstable, what do I need to do? If you don't need to do that, if it's a stable patient, you proceed to the physical exam, and we'll go through each screen sequentially. You get your physical exam here, and you'll have, as you see in a moment, different components of the physical exam that you can choose. After that point, then you're going to obviously start, you'll at this point certainly start ordering your tests, either diagnostic tests and or therapy. That takes you through the remainder of the case until the conclusion of the case, when the screen prompts you, end of case in 5 minutes, put in any additional orders you may have. Okay? Once you see that 5-minute screen, a door has closed behind you. All right? Because you can only go forward with orders. You're not going to even get results of those orders. At this point, you better do what you think needs to get done. You're not going to get the results of your tests. You're not going to find out the follow-up of that patient. Put in what you think needs to be done. If thinking about something that you put in there needs to be removed, remove it. But you're not going to get any additional information. It's your chance to try and get things done before the clock ends entirely. And the very last screen, the conclusion of the case, they will tell you type in your diagnosis. All right, so the chief complaint screen, you're going to get 1 or 2 sentences. It's going to tell you the chief complaint, where the patient is, which might be the wrong place. all right? And if that patient's exsanguinating in my office, maybe I'll put an IV in my office, and the computer might tell me, IV is not available in your office. Then I know the next thing I'm going to do is call for ambulance, which is not call for ambulance. I'm going to transfer the patient button to the ER, okay? If I could put an IV in my office, I'll put an IV in, then transfer the patient to the ER. It would be nice to have IV access while the patient's on en route to the hospital, all right? So remember, the patient is in a certain area, but it might be the wrong area. Is the patient stable or unstable? Sometimes from that first sentence you'll know, and it'll prompt you to pay very close attention to the vital signs, and obviously you should know what normal vital signs are. They're going to work in metric. Hopefully they're going to also give you English version. On the CD-ROM, for instance, they don't give temperatures in Fahrenheit. It's only in centigrade. Hopefully on the exam they'll give you both, but get used to thinking in terms of temperature of centigrade, all right? You should obviously know what a normal pulse is, respiratory rate, BPs, and if the vital signs are normal, it might rule out a lot of possibilities. Patient comes in with severe chest pain, has a heart rate of 68, blood pressure 120/80, is breathing at 12 times a minute. I don't think that patient has a dissecting aortic aneurysm, all right? So the vital signs can also, besides telling you stable or unstable, if you decide the patient is stable, you could cross out a whole long list of things that you might have worried about if the patient was unstable. But again, after that first screen, the chief complaint, I'm not yet making a differential diagnosis. Not enough information there yet. And again, the vital signs, you're going to stop at the end of the vital signs and say, is this going to be a stable patient or unstable patient? Because if it's an unstable patient, you're going to remind yourself, as soon as you finish that HPI, stabilize the patient. Okay, now the HPI, usually, I would guess that you'll be able to make the diagnosis after the HPI. You would be writing down your pertinent positives and negatives, and you should ask yourself, if you're not sure, what's the short differential, and, because it's about to come up in one or two screens, what are you going to need to help you distinguish between the things on your differential diagnostic list? You might get the answer, and hopefully you'll get the answer just from the next screen, the physical, all right? But you should be concentrating, thinking through the physical, and what you'll want to order on the physical based upon your differential diagnosis list. You should not even go into the physical without writing down your differential diagnosis. If you have this vague and fuzzy concept of what the patient may have, you're going to be reaching out for too many options. You have to narrow your possibilities. And if you just read the HPI and say, well, it sounds like shortness of breath, chest pain, it's some kind of heart, lung sort of thing. All right? Well, what kind of sort of heart, lung sort of thing? All right? Because you might want to do, on that exam, look for peripheral pulses, if it's some kind of heart, lung sort of thing. Another time you might say this hyperventilation. Do I just need to do a good neuropsychiatric exam as a key component? You need to have a firm differential diagnosis on your little scratch pad by the time you finish your HPI. Now, this is when you start getting your opportunity to choose things. And again, very often it might be the physical, but if the patient's unstable, you're not going to start the physical yet. Okay? The 4 buttons you will have at the top of that screen, and you should have this on your fingertips. You should know this back and forth by the time you take the exam, because you've done the 5 released CCS cases that the USMLE has provided for you, and hopefully you've gone through them many times, and not to convince yourself that you got the right answer each of those times, but to try and plug in different wrong answers to see where the algorithm, where the computer program takes you, to get a familiarity with how the computer thinks. All right? And I am not a computer whiz. I know nothing about computers, but after having sat with these cases, each of these cases, and trying to put in as many different possibilities as I can think of, and then trying to be very creative and doing some really bizarre things, you get a sense of how the computer thinks. And the computer will give you instructions. The patient you might get a note from the nurse telling you something that should prompt you, I really did something wrong. The computer's trying to give me a nudge, a clue that I'm on the wrong track here. And you will see how that happens, again, by going through many, many different scenarios that you plug into the computer. And as we go through the case that we've written up, I'll show you what could happen picking some really bizarre choices. You have the history and physical. Now, you've just done the history, all right, but you get an interval history, which means what has happened since you did the last thing you did. Well, you just finished taking a history. Asking for additional information is unlikely to be of any value. Does it cost you points? No, but it will cost you time. And if it's a very sick patient, it might cost you some points. Asking the same questions again. The physical exam will show you what the screen looks like and how you have to then decide what components of the physical you want. The button you'll probably refer to most during the exam is the write the orders and the review the chart button. And we'll talk about the different options you have in the write orders or review chart. Obtaining results or seeing the patient later. This is the part that will be the most new to you because it is the most artificial, because you have to move the clock ahead. And we'll talk in detail about this concept of how to move the clock, when to move the clock, what happens when you don't move the clock, what's happening behind your back when you do move the clock. We'll talk about that in detail. And changing location is something we could easily forget if we're paying attention to how sick this patient is and we forget that the patient is still sitting in our office. Or on the other hand, the patient is very stable, and we say we'll see the patient in a week, and he's sitting in our office for a week, meaning he hasn't had a chance to eat, he's peeing on your carpet, he hasn't had a chance to go to the bathroom. It's a mess. You got to do stuff for the patient. If you think they're stable and you don't want to see them for a week, send them home. You don't want this guy loitering in your consultation room for a week. Now, the history and physical button. You get a complete physical or a directed physical and the interval history, which we just discussed. Usually you're going to do a physical exam next, but again, as I keep repeating, sometimes before the physical you need to stabilize the patient. This is your opportunity to gain some big points. This is your opportunity to lose some big points. At the end of this session, I'll review with you what the USMLE has told us about their scoring system. Told us meaning anybody who's looked at the CD-ROM. We don't have any information that you don't have. And we've given it some thought about what they're telling us. They are obviously not going to give you their scoring algorithm. The USMLE has spent years and a fortune designing this particular program, and they're not about to give away the software to this program about how their algorithm is created, how their thinking goes. But they give us enough information that it's a very useful guide to indicate to us how they're going to score this exam. What I will do in terms of taking you through this strategy and through these cases is I will refer to things as +1, +3, and +5, and -1, -3, and -5. The USMLE does tell us that there are maneuvers that you do that will gain you more points versus less points. And there are maneuvers that you do that will cost you less points or cost you more points. In the old days, way back, on one generation of exams, for instance, the internal medicine exam used to have this, there used to be a paper and pencil test that was sort of similar to this, way before they knew how to write software. This was probably in the early 80s, where they gave you a case, and then they gave you a secret pen. And it was a marker that if you wiped out a choice, you would get the answer to what that test shows. For instance, you had a patient with shortness of breath. You had a list of 20 different tests they offered you. Here they're offering you about 12,000 options. There you got an option for 20 different tests or therapies you could do for the patient. You took your pen, and if you wrote over, say, chest x-ray, under that chest x-ray now would appear the results of that chest x-ray. And the way they would score that, if that chest x-ray was essential, you get +5. If that chest x-ray was not terribly important, you might get 0 or +1. If you ordered a thoracotomy in a patient who had a bronchitis, you'd probably get -5. All right? The same concept is what I think the USMLE will be using. And again, there is more than one right way to manage a patient, as in real life. All right? And I will give you sort of general guidelines as we go through cases, and we use different options about whether I think it's sort of a +1, +3, +5, -1, -3, -5. Okay? Now, when you choose the physical exam, you're getting lots of options. And you'll say, well, why don't I do a full physical, get as much information as possible? A physical exam shouldn't take too long. Physical exam shouldn't hurt the patient too much. But remember, there is a cost to doing a physical. First of all, if it's an unstable patient, you really are being tested to see if you know what is really essential and what is just a waste of time. And you can lose big points on doing things that are not necessary. In attention pneumothorax, you don't want to start doing a detailed psych exam. All right? You don't want to start asking them to do serial 7s or tell you why people shouldn't throw rocks at people who live in glass houses. Not important. All right? If this is the one you think you should be testing their proverbs, -5. You want to focus on what's important. Neuropsych sounds like an obvious one, but there are others. If you have a patient who's very unstable, you're not going to even look at their throat, perhaps. All right? Breast exam and rectal exam may or may not be appropriate, and sometimes they may be very inappropriate. So remember, just saying check all, get a complete physical, might cost you points. And again, if the patient is not stable, you better stabilize the patient before you order any physical. When you're writing the orders or reviewing the chart, that's when that blank screen appears, and that's when you might feel the initial twinges of panic, because now you have a choice of 2,500 orders and about 12,000 different terms in their menu. Do not, on the exam, hit A and try and scroll through their choices. All right? Say, well, I'm not sure what to do now. Let me see what they offer me. And start at A and keep your finger on the scroll button and look at about 12,000 options. Not an efficient way to spend your time. All right? You should know what you want. You type it in, and it will appear. Okay? You don't have to write words like give the patient this or administer this or call for. Very short, directed terminology. The computer will understand. If it doesn't, you'll get a screen of possibilities from which they ask you to choose. All right? When you're choosing drugs, you don't have to say, well, I know that it's called, and I'll use a drug name here, Tagamet, but I can't remember what the brand name is, what the generic is. Cimetidine. Type in Tagamet. It recognizes brand names. All right? And again, it recognizes brand names, remembers American brand names. There are drugs. It's not a joke. What is Tylenol called in Europe? Paracetamol. You write in paracetamol, they'll probably say, huh? All right? They may or may not recognize it. Meperidine, Demerol. In Europe, pethidine. I haven't checked, but I wonder if pethidine is on there. So you have to remember, at least has to be United States recognized terminology. And again, specifying a drug by class is not enough. You can't say calcium channel blocker. You can't say hypertension, antihypertensive. All right? Leukemia, some chemotherapy. All right? You'll get S, and it'll say S stands for, well, I don't want to say what S stands for in that case. You must specify the route and the type of drug administration, but fortunately not ask for the dose or the rate. If you don't specify the route, you say give penicillin. And you don't say how because you're not sure and you think you'll get away with penicillin, you're wrong. Any drug that for which there's an option, the next screen will be how do you want to give it? And it'll give every option. If it's a drug that can't be given more than one way, they won't ask you. All right? Tylenol, acetaminophen, they'll ask you PO or suppository. They won't ask you, do you want to give it through an intrathecal catheter? They'll give you those that are relevant. All right? And you can't get away from that. The rate of administration, you're fortunately not going to be asked, and the dosage you won't be asked. But, for instance, for fluids, you'll say, give intravenous fluids. Okay? Now, the first time you do that, that's reasonable to say, okay, intravenous fluids. Hopefully, you've done practice exams. You have given intravenous fluids, and every time you write in IV fluids, you'll see that they ask you which fluid you want. So save yourself a few seconds, and the next time you see it on the exam, when you want IV fluids, say IV fluids normal saline, or normal saline IV. The computer will recognize it in many different formats. Okay? And it will even recognize some misspellings, and we'll get to that in a minute. Okay? Now, on the right orders or review chart, most of the time, or the vast majority of the time, or just about every time you're pressing on the right orders or review chart, it should be because you want to write an order. The review the chart means it's just giving you a review of everything that's happened. It'll give you the HPI, it can give you past orders, it can give you past test results, but hopefully you're not going to need to resort to that too often, because that just means you forgot what the patient has. By all means, if you're not sure and it's important, go back. But remember, when you're ordering those things, you're not ordering a new test, you're not getting new information. It's just basically the patient's old chart. Old chart meaning from the minute you met the patient. All right? So hopefully you're going to have enough memory retention that you're not going to need to resort to that very often. Now, if you go to misspell a word, obviously you're not going to misspell anything deliberately, and if you misspell it, you're not deciding whether it's in the first three letters or the last three letters. But remember, the computer will recognize misspelling, but after the first three letters. There's only so much that the computer can guess for you. For instance, if you're writing nifedipine and you write NEF, the computer won't know to look under NIF. All right? It will look under the heading based upon the first 3 letters. You don't need to write out long, complicated terms if there's a simple common abbreviation. And if there's an abbreviation that you use and it doesn't fit, they'll tell you that there's nothing that matches your order. And a lot of these can save you some time. And again, as you're going through cases, get into the habit of seeing what's recognized. You should only write once in your lifetime complete blood counts, because you should also say to yourself, could I get it with a CBC? And if you can, write CBC. Now, some strategies on getting through the case. And again, I'm repeating certain things over and over and over because they should be ingrained in your thinking about getting through these cases. The HPI, you should only hopefully have to read it once. There's a lot of information on that page, and by writing down the pertinent positives and the pertinent negatives the first time, hopefully you're not going to have to go back to it. How would you go back to it if you wanted to? Would you try and hit the arrow that goes up and try and scroll back through the case? No. If you want to see the HPI again, you go to the Write Order or Review Chart button. That's the second button on the screen. And that will give you all the past information. You can't scroll back using the up arrow or a page up arrow. Okay? Hopefully you won't have to do that because, again, you're wasting real time. Always write down the patient's allergies. I always consider that a pertinent positive. All right? If the patient has an allergy, write it down because later when you start ordering drugs, make sure it's not something they're allergic to. Okay? When ordering tests, you might want to rattle off 6 things, just like they do on the show ER, and it's very impressive. You can say, give me a CBC, lights, Chem 7, LFTs, IV fluids, EKG, chest tube. It's very impressive, but remember, you don't need all of those right away. You might want a CBC and IV fluids. Get the result of the CBC before you decide on many other things. Or it might be perfectly appropriate to get a CBC, get type and cross, get an IV in, get an EKG, etc., etc. Okay? And again, if you have a choice between a test that you're going to get back right away and something you're waiting a week for, obviously get the thing that you order the test that you'll get back sooner. Now, I've heard a lot of questions about the role of consultants. And the USMLE actually addresses this specifically. What to do about consultants. The exam is testing your ability to manage the patient. They're not expecting you to be brain surgeons. They're not expecting you to be cardiothoracic surgeons. But on the other hand, they want you to know when it's appropriate to get someone to do a certain procedure. For the most part, they want you to manage the patient. Now, obviously, if there is a test that you're not expected to do, like an emergency endoscopy, or taking the patient to the OR to do a brain biopsy, if you order those tests and you're not qualified to do it, the computer will prompt you to say, you will need to order a neurosurgical consult before you do a brain biopsy. Because on that guy with diarrhea, on the released items, I kept trying to do a brain biopsy just to teach him a lesson. All right? And they kept telling me you need a neurosurgeon. All right? A couple of times I tried to take the patient with a pneumothorax and take out his colon, as you've heard before. In fact, when I did that, on some scenarios, they said, okay, colon is removed, no cancer is found, a normal specimen. On many other occasions, when I tried to do something really bizarre and painful, the disclaimer that you would get on the screen is, after explaining the risks and the benefits, the patient refused to consent to the procedure. That's probably a good clue that you shouldn't have offered it in the first place. All right? My guy with 3 weeks of diarrhea did not want a brain biopsy. I couldn't figure it. And you know, the next thing I actually did is I tried to sedate him. I actually tried to give him Demerol and Valium and Phenobarb to make him so groggy that I could just wheel him into the OR. And every time I sedated him, they said, the order is given. I'd say, can I do a brain biopsy? They say, patient still refuses to give consent. Don't do this at home. All right? Don't do this on the test. Okay? Now, the role of the consultants. You will rarely lose points for choosing a consultant unless you're wasting time waiting for a consultant when you should be doing something. If it is something for which you need a consultant, the exam will say the screen will prompt you, first you must order this consultation. If you order a consultation, for instance, for that guy with diarrhea, you say, okay, he has diarrhea. Let me get the GI consult. And you say, order GI consultant. They'll often ask you, why do you want the GI consultant? You can't type in, because I have no idea whatsoever what to do with the patient. You won't get big points for that. What they will say is, why do you want this consult? or the consultant arrives and has nothing to offer for this patient, continue to manage the patient. All right? Now, sometimes it's appropriate to call a consultation, someone with a dissecting aortic aneurysm. It's appropriate to call the cardiothoracic surgeon right away. One of the released items, I called the cardiothoracic surgeon very early in the case. Perfectly appropriate. Someone's dissecting. I want to have that cardiothoracic surgeon get out of bed, come to the hospital. I wanted to get the OR ready. I want to make sure the team is ready. Certain things don't happen instantly. So that's appropriate. They'll say, cardiothoracic surgeon is called and will shortly be available. Right? Or cardiothoracic surgeon will be available in 1 hour, indicating to you, manage the case yourself. Remember, again, most of what you'll be asked to do is not in terms of great diagnostic difficulty. Excuse me. It's just the starting point for how to narrow your differential diagnosis and then treat the patient appropriately. And if you're confident in the diagnosis, and very often you'll know the diagnosis for certain after the HPI, don't start doing a lot of confirmatory tests, even though it's something you've been trained to do in real life. Well, why don't I get patient has GI bleeding, why don't I get an abdominal x-ray? Absolutely wrong. There's no reason ever, almost never, to do an abdominal x-ray in someone with GI bleeding. You know the patient has a massive variceal bleed, don't waste time with an abdominal x-ray. Or even when it's something that's not emergent and you know the diagnosis, don't waste time and money. The CCS has indicated, the USMLE has indicated that one of the things they are factoring in is how effectively you manage the patient, not just in terms of efficiency, appropriateness, but also cost. You don't have to go and memorize what different tests cost. But if you have a chest x-ray that will suffice, you don't want to order a CAT scan. You say, well, CAT scan, let's say I do it without IV contrast. There's no risk. Maybe a little bit more radiation. Yes, but there's a cost. All right? And don't automatically assume, let me get the most possible information. If in real life you know you'd have the information with the simple tests, make the diagnosis on the simple test, sometimes just from the HPI. And remember, besides expense, there's risk of many procedures, and there's also time, not only to order the test, but to wait till that test gets done. And we'll talk about that in a few minutes when we talk about moving the clock. Now, the button that is often the one that causes the most anxiety is the obtain results or see patient later, which is essentially moving the clock button. And again, when we're going to talk about this, I want you to think about real time, the time that will be on the bottom of your screen. They tell you, you have 12 minutes left, or there is a lapse time, 15 minutes have gone by. That's real time, and you should be paying attention to that, versus case time. There are a number of ways to move the clock. They all start by hitting obtain results, we'll see the patient later, and then you get a number of options. One of the options is see the patient when the next test result is available. And that will bring you to when that test result is available. And you've been told when that test result will be available. If, for instance, you need a CAT scan result and it's not available for 4 hours, and you say, go to the next test result available time, it's 4 hours, you have to remember, your patient has just sat there for 4 hours with nothing being done. If they were short of breath, you haven't done anything for the next 4 hours. You might say, well, I need to get this CAT scan. That's the most important thing I need to do. Yes, it might be the very important thing to do. You might need to make your next major decision based upon that test result 4 hours later. But remember, your patients hang around wherever you left them. All right? And that's the part that's the least intuitive. Right? In real life, we say, I'm going to order a CAT scan for you. You're sitting in the emergency room. You know that the CAT scan is being ordered. You're going to send the patient there in 4 hours. The patient's right in your face. You're not going to say, okay, I can't do anything until your test result's available. It's obvious with the patient there. You're going to give the patient oxygen. You might order additional tests. You're going to address the patient. You don't have a real-life patient sitting in front of you on the exam. It doesn't mean the patient is stable. The patient's going to hang out wherever you left them, and they're going to stay there in that position, in that clinical situation, until you get the test result. More likely than not, if it's an unstable patient, by the time that test result is available, you will get a prompt. Nurses note the patient is far more short of breath. The patient is getting agitated. The patient has stopped moving. Exit case. All right? Remember, and I've tried doing this. I say, okay, I'll see this patient with a pneumothorax about a month from now. All right? They'll actually prompt you an hour later. They're not going to say it's a week later the patient's about to die. 10 minutes later, an hour later, patient's getting more agitated, more short of breath. I said, I don't care. I want my test a month from now. An hour later, patient is extremely agitated, very cyanotic, gasping for air. I don't care. I want my test result 1 month from now. Next nurse's note, it's 2 hours later, patient has stopped moving, is no longer breathing. You probably are not going to score too many points on that case. All right? You're going to get the exit button. You'll say type in whatever you want. Call attorney. Call funeral home. Please get me to the next case. All right? The exit case, when it comes real quick, is often not a good sign. It might be that it's a very simple case and you did everything right and they're saying this guy knows how to do this question, let's move on. Or it might be that you and the patient are in so much trouble that they're getting you out of there. All right? So remember, nothing happens to that patient when you jump the clock forward. You can't say that this is a stable patient. I've done everything I need to do for this patient. I want to see this patient in a week from now. That's fine. If it's a stable, chronic problem, you've addressed the problem. You say, I want to see the patient a week from now. Send the patient home. See them again in your office 1 week from now. You'll be able to type into the window number of days, number of hours, etc. Or they actually give you a calendar, and you can just click on that calendar day when you want to see the patient next. There's a choice to forward the clock to whenever the patient needs to call you for a problem. You're not going to want to choose that very often unless you've totally solved the patient's problem and the patient has been already seen in follow-up to make sure this is still stable. Then I might say, you know what, this was a self-limited problem. The patient had a bronchitis, a streptococcal bronchitis. I treated the patient with penicillin. I saw the patient a week later. I even saw the patient a week after that. Now I can either exit the case or say, call me if you have a problem. All right? And if you've managed the patient right, and the pneumococcal or streptococcal bronchitis got better, they'll say exit case. You type in any orders. In that case, there might not be any. Type in diagnosis, and you're out. Okay, remember, the case time, on the other hand, we talked about what happens if you move too quick. The patient languishes or can deteriorate. But on the other hand, the patient doesn't move forward either unless you move the patient there in time or in place. Patient ain't getting to the ER by hitchhiking. You got to call the ambulance, send the patient to the ER. All right? And that's in change location button. You don't have to type in call ambulance. Change location. After you've stabilized the patient in the ER, maybe the patient could go home. Maybe the patient needs to go to the ICU. Maybe the patient needs to go to the medical ward. You need to decide these things. If you stabilize the patient in the ICU, should the patient go home from the ICU? Think about it. How often have you sent patients home from the ICU? By definition, if they're real sick in the ICU, it's going to take them a couple of days to be really well enough to go home. All right? From ICU, they'll usually go to the floor. From the floor, meaning the medical ward, they'll go home or to your office in a week, let's say. But again, you have to move the clock and change the patient's location to get them there. And again, moving the clock doesn't move the patient. You've got to move the patient with a separate order on the change location button. Okay? Remember, you can't keep rushing ahead to get test results because your patient is not having any treatment during that time. Say, I need that test result a day from now. Think about what you need to do for that patient during that day. Now, remember, and I've given you several examples where I tried personally to very, very hard to kill my patient or to do cruel and unusual things to them just for fun. And usually the patient gets worse. All right? Most patients with traveler's diarrhea won't get better with a brain biopsy. And the question and the computer will let you know that. On the other hand, there are times where you might do the right thing for your patient, and just like in real life, no matter what you do, the patient gets worse, and you'll try something else, and the patient gets worse. You try one last thing, and the patient dies on you. That might happen in real life. It might happen on the exam. Don't panic. It might be that that's how this case is going. And they want to see that as the patient gets worse, despite what you're doing right, you know what the next right thing to do is. Okay? But again, if the patient gets very bad very quickly and the exit case screen comes up early, you probably did something wrong. Or you probably didn't do something right. Remember, there's errors of commission, meaning doing the wrong things, and there's errors of omission, failing to do what's indicated. Now, once you've treated the patient, especially if it's a stable patient, you sent the patient home. There was a rheumatoid arthritis question on the USMLE CD-ROM. You figured it out. You gave the patient NSAIDs. It took me several visits till I found out the patient was entirely better. I saw the patient at 1 week, she still had some pain. I saw the patient at 2 weeks, I think she still had some pain. By the second or third follow-up visit, the pain was completely gone. What do I do with this patient now? Well, if I thought you had rheumatoid arthritis, this is not a self-limited disease. This is not a pneumococcal bronchitis. This is a chronic patient. So I won't say, I'll never see you again, exit the case. I'll say, I want to see you again now, maybe in a month. Or maybe call me when there's a problem. But a patient with a chronic disease, I'd like to be a little bit more proactive. And I'd like to say, okay, come back and see me in a month. I see the patient again in a month. The patient was perfectly well. No new problems had arisen. Her joints were fine. She had no toxicity from her medications. Then I might say exit case. Anything else I want to do? No. Type in diagnosis, rheumatoid arthritis. Okay? Now remember, and it took me many times of going through questions until I stumbled upon this choice, is that there are times, or many times, where it's appropriate to counsel the patient. How do you do this? If I want to talk to the patient about safe sex, the patient has an STD, sexually transmitted disease. You make the diagnosis in bang, 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 3 steps. All right? You got a urethral culture, you did the Gram stain, you did you saw the gonococcal organisms, you gave a shot of ceftriaxone, you said treat the part, you tell the patient bring your partner in so they could be treated, and then you said exit the case, or I'll see the patient in a week and the patient was fine, exit the case, you will lose points. Why will you lose points? You didn't talk to the patient about safe sex. All right, if you type in safe sex, I don't think it'll come up on the screen. They'll probably say no match, and they might just give you different things that start off with SA. I'm not sure about that, but what I found is if you want to do any sort of counseling, you have to type in the word counsel, and then you get about a choice of 50 things you want to counsel the patient about. Everything from safe sex to, in this patient, I also should have talked about HIV risk factors, to wearing seatbelts, okay? Gonococcal patients don't need to wear seatbelts, okay? But in general, there will be many things that you should ask yourself, especially if you're ready to discharge the patient, is there anything I should counsel the patient about? Okay, when I typed in weight loss, I couldn't get it. When I typed in counsel and dietary, I got it. Okay, and you type it in, it says confirm order. It says the patient has been instructed about the value of a low-calorie diet. All right, remember, don't forget the counseling issue. It's an easy way to pick up 3 points. Okay, and it's hard to lose points by counseling the patient about diet or safe sex. So when in doubt, give the patient some good, useful information to go home with. It's a free way to pick up some points. Now, we talked about what you do in terms of the routine visit. You'd like to make sure your patient got entirely well, and then usually I like to see them one more time to make sure that they stay well. If I have a patient with RA, for instance, rheumatoid arthritis, and I got better with my aspirin or my NSAIDs by the 3rd visit, I bring her back in a month, she's still fine. I bring her back in another month, she's still fine. I bring her back a month later, she's still fine. I'm not really losing any points there, I don't think, because I'm not really doing anything negative to the patient. I'm counseling the patient, perhaps. But I'm wasting time, all right? And I really probably would like to save that time for mental peace and quiet between cases. You're not going to get extra time for the next case, but there's no point in just repeating something that you know is redundant and not adding any additional information. Before I would exit every case, I say to myself, should I counsel this patient? Maybe a patient with rheumatoid arthritis, I want to talk to her about counsel her about some safe exercises, range of motion exercises. Again, it's a way to pick up an extra point or 2. Now, if your patient gets worse, again, it might be because you got the wrong diagnosis. All right, you missed the diagnosis, you missed the tension pneumothorax, you're in big trouble, patient's going to get bad in a hurry. You might have made the right diagnosis, but you're treating the patient with the wrong therapy. All right, you might have made a diagnosis of Legionella pneumonia in a patient, but you're treating the patient with gentamicin. Patient's going to continue to get worse. Doesn't mean you have to rethink the diagnosis. If you look at your pertinent positives and negatives and you're sure of the diagnosis, ask yourself, do I need another treatment? That patient with Legionella is getting worse, I'll go back and say, give erythromycin. How? IV. See the patient a day later, they're much better. Okay? And remember, you can have the right diagnosis, the right treatment, and the patient might still get worse. And again, don't necessarily have to doubt yourself. If you're certain you're on the right track, you might very well be, and in real life, patients still get worse. The changing the location button. This is very important. We've discussed it now a number of times. Patient doesn't get anywhere unless you send them there by pressing the button. All right? And if you're sending them elsewhere, let's say to your office or to their home, the computer will prompt you and say, when do you want to see this patient again? And if you do admit the patient to the hospital, they'll prompt you, Okay, you put the patient in the hospital, you can't say, I want to see the patient in a day. They'll prompt you to write orders for that patient. Remember, just by moving a patient, you can't dump the patient, all right? You can't say, oh, patient's bleeding in my office, having chest pain. Let me call 911, get this patient out of here, press the button, send the patient to the ER. Ooh, I'm free. Go back to office hours. My date is in about a half hour. I'll be out of here just in time. No, you got to get to that ER and continue taking care of that patient, all right? If you're saying, well, I saw the patient in the ER, I'm a hotshot ER doc, I stabilized that patient, I gave them the thrombolytic therapy for their hot MI, I'm sending that patient to the ICU, I'm out of here. No, you're not out of there. You're up to the ICU with the patient, you're going to continue managing that patient, all right? It's your worst nightmare. The patient never leaves. Okay? Now, at some point, hopefully not after your first order, you're going to be told that there's only 5 minutes of real time left. All right? And again, it could be a good indicator or a bad one. And you'll have, if the sweat's pouring down your face and your heart rate's 150, and you see end of case, you're probably right to be sweating and tachycardic. If you're really unsure about what you're doing and the patient is crapping out, it's probably because you missed the diagnosis or you did something grievously wrong. On the other hand, if you're sure you're on the right track and the patient's getting better, end of case is wonderful. It means you'll be home at the end of that day 20 minutes sooner. All right? So don't panic if it's the end of the case, exit case in 5 minutes if you've been doing things right and the patient's getting well. Now remember, when you see that 5 minutes left, there's several things will happen. The doors close behind you. You can't even go back to review information that you were given. You should stop and say to yourself, why am I being thrown off this case so early? Why is this patient crashing? And you say to yourself, wow, I really did miss a tension pneumothorax here. He was a COPD patient, he was coughing, he had severe pleuritic chest pain. I remember the trachea was deviated, I had no idea why. It was a pneumothorax, it was a tension pneumothorax. Patient's hypotensive. You can't go back and get a chest x-ray. Right? You can't even go back and confirm those details in the history and physical. But what you can do is you can then do the appropriate therapeutic maneuver. Or if it's something that needs to be ordered for diagnosis, you could do the appropriate diagnosis. You can't review any information, and there's no test that you can order for which you'll get your answer back. If you order a chest x-ray, a portable, stat portable x-ray, and you say, gee, I should have had that test result in 2 minutes, the 5-minute block of time at the end prohibits you, prevents you from getting any new information. It's just your time to order any appropriate diagnostic test that should point you to the right diagnosis, and then make a good guess about what the patient really has and treat it. And then the final question will be type in your diagnosis. And no matter how vicious you've been, they will always thank you for taking care of the patient. Isn't that special? Okay, so let's just briefly review some of the ways that managing this case is like it is in the real world, and some ways in which it is artificial and different. Remember, we're managing a patient here and not just a disease. You've got to remember that things need to be done to the patient and not just ordering a list of tests and medicines. The patient has to be sitting in front of you when you're sitting and taking the test. You have to remember that there's a patient there that will need attention. Okay? Just like in the real world, you're not getting a list of options. You need to consider on your own what this patient needs. All right? Even if you're doing everything right, the patient can get worse. Okay? It doesn't mean that you need to go back and change your diagnosis. And, just like in real life, once you've done something, you can't undo it. Now, let me be a little bit more specific. If I order a chest tube in someone, and I put that chest tube in, and I say, you know what? I think this patient had asthma. I can't go back and say, forget that chest tube. That chest tube is in. The lawsuit is in. Okay? You can, once something is put in, you can remove it. But again, once something occurs, you can't undo it. And again, in the real world, we just got to sit and wait for time to go by. On the exam, you have to prompt the clock to move forward. Okay? And remember, you need this artificial exercise in visualizing the patient in front of you. Because if you move the patient, if you move the clock a week ahead, you have to think, what's happening to this patient who I left sitting there? All right? And again, if you're the ER doc in the real world, you send the patient up to the ICU, you say, gee, I'm clear. Here, you follow the patient. Now, a couple of points about the way the test is scored. Again, I'm not giving away any secrets. This is all information that's on the USMLE CD-ROM. They tell us that the management decisions you make are scored with a varying number of points based upon what you're doing, based upon how appropriate it is, not only if it's the right thing to do, but if it's the right sequence in which to do it. Okay? You'll order a chest x-ray, for instance, before you order a chest CAT scan in most cases. All right? You'll order a blood count in someone who is bleeding before you order the endoscopy, because you think about it, the endoscopy will take an hour or two to get arranged perhaps. You order the CBC because you might have that back in a few minutes. Okay? So if you order aggressive things before you've done the simple diagnostic or the simple therapeutic things, you might lose points for that. Okay? Doing something that's painful or harmful, well, obviously a lot of things we do to patients are painful, but if they're harmful, they were the wrong thing, putting a chest tube into asthmatic, that's -5 in that scheme of -1, -3, -5. And again, there are things that you might not think are terribly painful but are inappropriate. A 19-year-old woman comes in with anxiety attack and hyperventilating, you're not going to say, I really would like to do a breast exam on this woman. All right? There are things that are not necessarily painful or wrong, but they're just inappropriate for that clinical situation. You have to consider the cost. All right? If you have two antibiotics, and one is a 19th generation quinolone, and another one is penicillin, and things respond to penicillin in that case, use the penicillin. All right? Some cases you might get through very quickly. You'll have the right diagnostic test ordered. The diagnosis is clear. You treat the patient with steps 1 and 2. Patient's better. You see the patient follow-up. Patient's still better. That might be the end of the case. It doesn't mean you did something wrong. And again, remember, before you exit a case, especially in the chronic patients with chronic diseases who are stable, ask yourself, is there anything I can counsel this patient about? Health maintenance issues. And there might even be questions, although they weren't on the CD-ROM, where they give you a patient who is a well patient for a periodic health exam. And they might give you some minor complaints in the history of present illness. They might give you some minor abnormalities in the physical exam, and they'll want to know how you follow up on those. Or they'll give you nothing wrong, or some minor things wrong. You do the simple, safe diagnostic and therapeutic maneuvers. And if it's a 52-year-old, you'll say, by the way, I need to do colon cancer screening. I need to make sure this patient had a mammogram. I need to make sure this patient had a pap smear. All right? So don't forget the routine examinations, especially in the well patient for a periodic health exam. Once the case is over, forget about it. You can't go back to it. You're locked out of that case. Take a deep breath, move on to the next one. Remind yourself that at most, at the present time, and this might change with subsequent cycles on the exam, at most the CCS will count for 25% of your grade. All right? And you should be practicing with the USMLE cases time and time again. The first time you do it, if you haven't done the cases the first time yet, you should be doing it so you can actually, as you would on the test, get it right the first time. And then once you've done that exercise, go through the test offering slightly or subtle wrong answers, and then see what happens. And you might not learn much. If it's a subtle wrong answer, you might just be getting scored negatively, and nothing much changes with the patient. But if you do things that are really wrong, you might find that the case itself prompts you in a way to redirect you onto the right path. Okay? Remember also that there are more than one way to manage patients. You might do a slightly more detailed, but not painful, not invasive, not costly way to diagnose a patient. And you might get the same amount of points, not more, not less, than if you were able to make a diagnosis with one test and start treating the patient with one test. The CCS is clear. The USMLE is clear in saying that there are a wide range, not infinite range, but a wide range of managing patients correctly, that they recognize that there are many ways to do things that are acceptable, and that you can talk to someone else who might have handled the same case. And again, people taking the exam on the same day might have 9 totally different cases, but you might find that you both had a good outcome and that you both scored the maximum number of points. Now, with those guidelines, we are going to now move forward to do a case which we've written. It's in addition to the 5 cases that you should all go through, to take you through the case with these various strategies that we just discussed. First screen, just like you'll see on the exam. A 24-year-old white woman presents with diarrhea and abdominal cramps. She appears well-developed and comfortable. It's day 1. She's in my office. Can I make a differential diagnosis here? Don't bother. Is she stable or unstable? I would guess that she's stable. Vital signs. Temperature, looks okay. Heart rate, okay. Respiratory rate, okay. Blood pressure, okay. Height, and hopefully they'll give this to me in feet and inches as well. I guess is about 5'7", and her weight, and I might be wrong, but the weight in kilograms is about 120, 130 pounds, 110. All right, so she's stable or unstable. Before I look at the history, key point, stable or unstable? Stable. Stable. Good. Chief complaint, diarrhea and abdominal cramps. All right, and again, you might see this on your screen, and it'll probably say in the lower right-hand corner, it'll say more, meaning you will need to get more information by scrolling down. On this screen, this might not be all the information you'll get in the HPI. In the lower right-hand corner of the screen, there will usually be an arrow that says more with a downward arrow. You click on that and it might give you more HPI, or we'll start the review of systems, allergies, past medical history, etc. Okay, let's read this one. The patient is a 24-year-old women's fashion wear designer who was well until approximately 2 months ago. Okay, and again, I have my little pen, my little marker they've given me, my scratch pad. I'm going to write down what I think is pertinent positives and negatives. Okay, well until 2 months ago. All right, is that pertinent? I would say yes. Fashion wear designer? I don't think so. At that time, she began noticing an increasing frequency of bowel movements, up to 6 times a day. All right, 6 to 8 times per day for 2 months now. Stools range in consistency from semi-form to loose and occurred more frequently after meals, postprandial. The bowel movements were often preceded by cramping in the mid and left lower abdomen, left lower quadrant cramping. 3 weeks ago, she started noticing small amounts of bright red and dark blood mixed in the stools, which has gradually increased, particularly over the last week. So 3 weeks, bloody diarrhea. She has also begun awakening once or twice nightly with loose watery stools mixed with blood and mucus, nocturnal. She has unintentionally lost 4 kilograms over the last month and attributed this to a diminished appetite. So we have 4 kilograms, weight loss, anorexia. She denies any prior episodes of bloody diarrhea, but recalls a 2-week period of watery stools while on an expedition in Guatemala 4 years ago, which gradually resolved after some antibiotics. So what's that? I think that's a history of traveler's diarrhea a long time ago. I don't think it's going to help me right now. She last took antibiotics 3 months earlier for an upper respiratory tract infection and recalls that it was a sulfa drug. Is that relevant, that she had a URI? Does an upper respiratory tract infection have anything to do with 2 months of diarrhea and 3 weeks of bloody diarrhea? No, but antibiotics might. So I'm going to write antibiotics. Sulfa. She only took the antibiotic for 2 days, at which time she developed a diffuse rash and stopped the drug. Oh, sulfa allergy. Over the last 6 months, she has traveled to fashion shows in Paris, London, Milan, and Tokyo. All right, travel, is that relevant to diarrhea? Why do you say yes? Why is travel related to diarrhea? Because you could pick up a bug, get traveler's type diarrhea. Paris, London, Milan, and Tokyo, are there bugs that you would worry about in particular in those areas? Not really. So yes, she has travel. It's not areas that she's likely to pick up a traveler's diarrhea. Is it possible? Yes. But again, it's not any tropical area, any area which is known for poor water sanitation as a risk factor for traveler's diarrhea. Sexually active with 2 male partners and reports she is using a daily oral contraceptive and her partners always wear condoms during intercourse. Is that relevant? Well, it's relevant in that I'm told specifically that she doesn't have sexual risk factors for STDs or HIV. Have I heard anything about risk factors for HIV in this patient? No. And in fact, the one risk factor, which I would imagine she might be at risk for, sexual transmission, I'm specifically told she's not really at risk for. All right? So far I have 2 months of diarrhea, cramping, postprandial. It's been bloody for 3 weeks. It's nocturnal, anorexia. She's been on some antibiotics. Am I starting to get an idea of what this might be? Already I'm thinking several months. It's not a traveler's diarrhea. It's bloody. Sounds bloody. It sounds like there's some invasive process. I don't think she has an invasive organism because it's going on for a long time to have an invasive organism. She has some chronic diarrhea. It's a bloody diarrhea. Some chronic invasive itis. There's itis here. There's cramping. There's blood and mucus. Does she have a chronic infection? Unlikely. What might she have? Could she have ischemic colitis? 24. Well, she's on an oral contraceptive, which makes her a little hypercoagulable, but that's still a little far-fetched. Could she have a chronic infection? We said is unlikely. Could she have intestinal ischemia? Is this small intestinal ischemia? It doesn't cause bloody diarrhea, and she has no reason for that. So what am I thinking about? Chronic diarrhea, bloody, mucus, young person, Crohn's disease, or ulcerative colitis. All right? The pain is on the left side, okay? It's bloody diarrhea. Would I lean more towards ulcerative colitis or more towards Crohn's? Right, there's no right lower quadrant findings for Crohn's. It's bloody, which is more typical of ulcerative colitis. So on my differential, I'm putting UC and Crohn's disease. And I'm a little hard-pressed to even think of other diagnoses. Should I put ischemia further down? Maybe. Anyone have any other ideas? All right, so again, from the HPI, I'll usually be able to have a very short list. Here it's ulcerative colitis 1, Crohn's disease number 2, a distant third, ischemic colitis, maybe because she's hypercoagulable from oral contraceptives. All right, again, on the same screen, I just have scrolled downwards. Hospitalizations and procedures. She had a termination of pregnancy 18 months ago of an 8-week pregnancy. Insertion and removal of an intrauterine device 3 years and 2 years ago, respectively. Is that relevant? I don't think so. Infectious mono at age 17, recurrent left ankle sprains. Relevant? Low dose daily oral contraceptive? Maybe. I'm going to note that. OC, oral contraceptive. Sulfa, shellfish, strawberries, and tree pollen allergy. All right? I got to remember that, especially a drug, because I don't think I'm going to treat her colitis with shellfish, right? Vaccinations up to date, family history, father's alive, mother's alive, history of Graves' disease, irritable bowel syndrome. Oh, could this patient have irritable bowel syndrome? Diarrhea, young person, she's in a high-pressure industry. Does irritable bowel cause bloody diarrhea and nocturnal bowel movements? No. Does it cause diarrhea? Could the diarrhea go on for 3 months? Yeah, sure, it could go on for 3 years. Can it be in a 24-year-old? Is that the right age? Absolutely. What doesn't fit? Bloody diarrhea, nocturnal bowel movements. All right. Brother, age 24 with asthma. Sisters, 16 and 18 and alive and well. All right. Any more useful information here? Social history. See all this information I got to read? Again, I can't, even if the patient was unstable, jump ahead and start doing stuff for the patient. I'm forced to read all this information. Fortunately, this patient is stable. I'm not in such a hurry to do something for the patient anyway. All right, she's never married. She lives in an apartment with an art graduate student as a roommate. Doesn't smoke. She has a half a bottle of wine with dinner. Occasionally smokes marijuana. Last time a year ago. That relevant? Maybe she uses other drugs secretly, and she really has a heroin addiction and uses filthy needles and has HIV and has an opportunistic infection. You're thinking too much. All right? She smokes a joint a year ago. You don't have to put her in the HIV house. All right? Occupation, women's fashion wear designer, college graduate with the Bachelor of Fine Arts, tennis player, usually plays 2 nights a weekend on weekends, skis several weekends each winter. Sounds like a healthy young person. That's what I'm being told. What's in the review of systems? General skin. She had mild conjunctivitis. Mild conjunctivitis. That somehow rings a bell. Oh, ulcerative colitis, conjunctivitis. Does that mean it's ulcerative colitis because she had conjunctivitis? Of course not. Everyone could get a conjunctivitis. Musculoskeletal, cardiorespiratory, GI, we were told about. GU, we already got her sexual history. She had a negative pap smear. She's had a UTI 2 years ago. Okay? She had 2 acute panic attacks at age 17, and they haven't recurred. Is this panic attack? Panic attack, bloody diarrhea? I don't think so. Okay. All right. Now you're up. All right. You're at the batter's plate. What are you going to do? History or interval history? In other words, you just finished taking this history. You want to go back and ask the patient another history? Some more questions? Write orders or review chart? Well, what about the physical? I skipped the physical. Do you want to do a physical here? Yeah. Do you want to write orders before the physical? Do you want to obtain results already? There's no results to obtain. Are you sick of this patient? Want to throw her out of your office, see her later? Do you want to change her location? Where was she? Your office. Do you want to send her to the ER before you examine her? Examine her in your exam room. So I'm going to do a physical. Okay? On this screen, okay, as you have on the screen when you take the exam, you have, again, the choice of history interval follow-up, which is a waste of time in many or most cases. Physical exam, I could make one check mark and get a complete physical, or I could pick and choose, like in a restaurant. All right, a la carte. Now, do I want a complete physical in her? Yes. Is there anyone here who thinks that there's something in the complete physical which is just plain wrong to do in this stable young woman? Is it wrong to do a neuropsych? It's not wrong. Maybe she's depressed. Maybe she's anxious. She has these new symptoms. Anything wrong with that? Rectal exam inappropriate in this 24-year-old woman? Not with bloody diarrhea. It's not breast exam. Well, she's here for a first visit. I don't know if she's had a breast exam in the last year. I don't think I'd lose big points for doing a breast exam. It's part of an annual physical examination anyway. You're not going to lose points for that, I wouldn't think. And everything else here seems reasonable. All right? So I might actually here say complete exam. All right? If I was really forced to eliminate things, general appearance, let's go one by one. General appearance. Yes, it's always worthwhile to know if the patient, because first of all, it doesn't take much. You're looking at the person. Are they chronically ill, or are they acutely ill, or neither? Okay? Skin. Yeah, I want to know if she's pale. There are skin manifestations of IBD. It's easy to justify that. Breasts, routine physical. It's not high on my list of what I need. Lymph nodes. Well, maybe. Maybe she has some funny infectious colitis, and she'll have groin nodes. Lymph nodes is not going to be high yield, but not much downside. Head and neck, sure, IBD has lots of head and neck findings. There's a conjunctivitis, there could be uveitis, there could be cold sores in the mouth. I want to check her mucous membrane, see if she's dry. I don't really care much about her ears. So it's worthwhile doing a head and neck exam. And again, remember, the patient's stable. It's hard to lose points for simple things on the exam. Chest and lungs, it's hard to lose points for doing a lung or heart exam. Abdomen, obviously very high yield. Rectal, high yield. Extremities, clubbing. Do I want to see if she has clubbing from chronic inflammatory bowel disease? How hard is it to look at somebody's extremities? Look at her joints. Joints are involved in IBD. I think that's relevant. Okay? And neuro and psych. If someone had a gun to my head and said just pick a few, I'd say general appearance, skin, abdomen, rectal. Those are my main ones. But again, I don't think I'm losing points for doing a complete physical here. All right? Now, please, let's hold the questions. Please, let's move on. All right? Let's say this is what I ordered. Let's say I was being very miserly, and I only did a few things. I got a skin exam. I got general, skin, lymph nodes, head and neck, chest, lungs and heart, abdomen, rectal, and extremities. I said, you know what? I don't really need to do a breast exam in my office today. I certainly don't need to do it. Oh, I didn't discuss genitalia. Could this be Reiter syndrome? Could this be Behçet syndrome? I mean, I'm really reaching. Could the patient have vaginal ulceration associated with Reiter syndrome? Maybe. That's a thought. Sexually transmitted disease. Maybe this is a reactive arthritis. It's possible. So I wouldn't say genitalia is absolutely inappropriate. But again, it's a little lower on my list. Rectal and extremities I definitely want. Neuropsych, I didn't want to waste time to do. But again, I don't think I'd be in any trouble if I did a full physical. All right? And then on the next screen, I'm asked to confirm my choices. You could still say, you know what, I really don't want to do a full physical in this patient. Or, on the other hand, I want to do a little more. You're told how many minutes your whole exam is going to take. All right? And in this particular patient, the exam I ordered comes back with a price of 14 minutes. Can I afford to do that? Sure. Okay, so let's get our info now. She's well-developed, thin, comfortable, no apparent distress. Normal skin turgor, no abnormalities of hair, skin, or nails. Okay? She's not dry, hair, skin, or nails. Sometimes IBD associated with psoriasis. I'm thinking too much. Okay? Lymph nodes, they're normal. Head and neck exam, let me read through it. Everything looks normal. Everything looks normal. Everything looks normal. Everything looks normal. Okay? Took me more time to read it than to do it. Chest and lungs, normal. Heart, cardiovascular, normal. Abdominal exam, I got to pay particular attention. Scaphoid, non-distended, and normal bowel sounds. Mild tenderness to moderate palpation in the left periumbilical area and the left lower quadrant. Does that lead me more towards ulcerative colitis or Crohn's? Ulcerative colitis. No mass is palpable. Liver and spleen normal and non-tender. No inguinal or femoral hernias. Rectal, normal perianal area. Oh, that's interesting. Let's say it was Crohn's. This would be a place I'd pick up a clue. Maybe she has Crohn's colitis, and it only involves the left colon, and if they told me now she had a big perirectal abscess or draining perianal fistulas, wouldn't that be helpful? Yeah, it would. That was a rhetorical question. The answer is yes. Normal perianal area, normal internal and external anal sphincter tone, no masses, retroverted uterus, brown stool positive for occult blood. Extremities is normal. So, has the physical exam helped me limit my differential diagnosis? From ulcerative colitis, Crohn's, and ischemic colitis. I had ulcerative colitis at the top of my list before. Is it still at the top of my list? Yes. Am I willing to make a fairly firm commitment at this point that it's ulcerative colitis? Yes or no? Fairly firm, yes. Whoa. Let me go back now. And now we have to actually slightly go away from the CD-ROM or the CCS format, because again, now we have 12,000 choices, okay? And if you'll yell out choices, I can't give you the response to 12,000 different choices. But let's think about what we want to order now, and those are the things that we'll be able to order, and those are the things for which I'll give you results. And if you give me something that's ridiculous, I'll tell you the appropriate answer. All right, what do we think the patient should have? Our differential diagnosis, ulcerative colitis, Crohn's, ischemic colitis. What are the sort of things we want to consider? Now, is infectious colitis entirely off my list? No. And in fact, I think I would have made a mistake if I didn't just put it down on my list. Remember, can she have a chronic infection? It's possible. It's possible. It's a little long. 3 months is a long time to have an infection that hasn't made itself more evident yet. Usually a patient with an infectious diarrhea has come to the physician for attention before 3 months. But certainly in a young person, and remember, it's 3 months, it's not 3 years. If it's 3 years, I would really say this is stretching it. But are there chronic infections that can present like this? Which infection? Amoebic colitis could do this, right? Chronic infection, low grade. She's getting progressively worse because she's not treated. I really think it's probably a good idea to put this on the list and something I might have missed. Has she been to an area with amoeba that is high risk for amoeba? Paris, Milan, London, Tokyo. Not really. Is she participating in sexual tendencies, anal intercourse that would put her at risk? Even if she is, her partners are using condoms. So I don't have a sexual route of transmission. I haven't put her in a part of the world where she would get it. Could she get it eating at a fine restaurant, at a fashion show, after a fashion show? Is that possible? Is it possible that some kitchen worker brought some amoeba with him or her from another part of the world? Sure is. So remember, it's definitely still on the list. Okay? So, for ulcerative colitis, Crohn's disease, an amoebic colitis, or other infection, how am I going to start distinguishing these? What test would you like? All right, so I want a stool culture. I tell you stool culture will come back, well, I don't want to prompt you with all the other things, in, say, 2 days. Okay? What else? Do you want to move the clock forward 2 days, or is there anything else you want to order first? Anything else I want to order? Stool for ovarian parasites. Okay, ovarian parasites. That will cover amoeba. Sure, that'll be ready in 24 hours. Anything else I want to order while I'm at it? C. diff doesn't usually cause bloody diarrhea, but again, something I should put on the list because she was on antibiotics how long ago? Well, again, I might have to go back now to figure it out, to see exactly, but several months ago. So again, C. diff, all right, should be on that list. Now, I'm expanding the list to include things that I didn't think were in the top 2 or 3, and they weren't in the top 2 or 3 for good reason. C. diff doesn't usually go on for 3 months before the patient comes to the doctor. C. diff doesn't usually have bloody diarrhea. All right? What else? C. diff will take me 2 days to get back. What else might I want to do? Do I want to look at the stool for fecal leukocytes? Okay. Does it help me distinguish between what's on my differential diagnosis? No. Am I doing the patient any harm by looking at this stool for white cells? No. I'll get it back in a day. Will it distinguish between UC, Crohn's, amoeba, C. diff, ischemic? No. All those are inflammatory. They'll all be positive. That's the sort of thing that I might get a +1 for. A stool culture, I would say +3. Ovin parasites, +3. C. diff, +1. All right? Anything else anyone would want to think to order? CBC, someone's having bloody diarrhea, or be back later today? Yeah, +1 or +3. Electrolytes, make sure she's not hypokalemic from her diarrhea, +1. Liver function tests, maybe she has ulcerative colitis, she has sclerosing cholangitis. I'm thinking too much. Would I lose points by ordering LFTs? No. Maybe pick up a point. Sedimentation rate, very good. I'll have it back in an hour or 2 hours. And if it's very low, does that rule out anything? No. If it's high, does it rule in anything? No. But it's something I can follow as I treat this patient. Whatever she has, I'll start treating her. If the sedimentation rate was 90 and it goes to 50 to 20, I know I'm doing well. If a week later I'm treating her and the sed rate goes from 80 to 120, I'm probably doing something wrong. I'll give you a +1 or +3 for sed rate. Anything else? Flexible sigmoidoscopy. Now, am I going to tell this 24-year-old woman, you know what I'd like to do is I'd have you lay down, turn over on your side, I'm going to take this rigid instrument or this flexible instrument, put it in your rectum to see if you have ulcerative colitis. She'll say, well, can't we do anything else first? Which most patients will say when you show them what the instrument looks like. They say, yeah, I could do the cultures first, because if you have an infection, I might as well just treat you. Now, on the other hand, you'll say, well, it'll tell me the extent of inflammation if she has colitis, the severity. I would say that you're sort of in a gray zone. Maybe you should wait until you get the cultures back. Because remember, this patient's been sick for 3 months and not terribly sick. If she came back with an amoeba, do I need to do a sigmoidoscopy? Probably not. If she came back with a bacterial infection that's been chronic, do I need to do a sigmoidoscopy? Probably not. So I would say it's not what I would do on that first visit. I'd wait for my stool test to come back. Anything else anybody wants to do? CAT scan. What information is a CAT scan going to help? -3 or -5. It's expensive, there's radiation, and it's not going to help me. All right? What else? Barium enema. Is that going to be very helpful? I give her a lot of radiation to a young woman. Could it show me colitic changes in the left colon where she's tender? It can show me colitic changes. Will it help me distinguish between my possibilities? Between amoeba, Shigella, ulcerative colitis? Probably not. If it was Crohn's colitis and I had skip areas, it might be helpful there. But I know that a barium enema is not going to focus me on one diagnosis and will be the last diagnostic test I need. I would say barium enema, I'd give you -1 at least, maybe -3. But it's relevant. I don't think I'd get -5 for that. What else? Obstructive series, KUB. Abdominal x-ray. Does it help me in a patient who's not sitting there with what I think is a toxic dilation? No. Is it much of a downside for an abdominal x-ray? No, I'd give you a -1 for that. Not necessary. It's not helping me distinguish between my possibilities. Think about it. A patient comes to you with bloody diarrhea. Do you say, go get an abdominal x-ray? What's that? Colonoscopy. Colonoscopy will tell me not only if it is colitis, the extent of the colitis, the severity of the colitis, not only the rectosigmoid, but the entire colon. You would say, let me do that. Take a bowel prep, come back in the morning, I'll do a colonoscopy. Instead of putting in a tube that's this long, young lady, I'm going to put a tube that's this long. Oh, really, doctor? That looks like it's not terribly comfortable. Have you ever had one, doctor? No, and I probably won't for a number of years. Well, why should I have one? Well, I could tell you if you have colitis. I could tell you how severe. I could tell you how much of your colon is involved. Well, how are you going to do that? You know, the colon is not a clean place, doctor. What do I have to do? Oh, you have to drink this gallon of an electrolyte lavage solution tonight. Stay home tonight because you're going to have about 30 bowel movements to clean you out. Or I could give you 2 glasses of something called Fleet's phosphorus soda that'll taste vile and also send you to the bathroom 30 times. And then when you come in, I'll be nice to you. I'll give you some IV sedation to have this colonoscopy. I'll charge you anywhere from $600 to $1,200. And after sedation, you'll probably have to take the rest of the day off. Is that what you want to do in this patient at this point in time? -3, -5. Might it be useful at some point in this patient? Yes, at some point in the near future, it might be the +5 exam. But at this point, I would say too invasive, not necessary, too expensive, too uncomfortable, etc., etc. You'd lose some points there. Okay? Anything else? Stool for occult blood. I told you on your rectal examination that it was guaic positive. So if you want to ask for it again, you probably lose a point wasting some time. Okay? You didn't believe your first guaic exam. Okay, let's move on. So let me give you the range of answers for these various tests, and I gave you a sense of what I think is more appropriate, gets you the bigger points. What is less appropriate has you lose some points. Stool culture and sensitivity. First, I'll tell you, you'll get it back on day 3 at noon. Because remember, when you order a test, you're told when it'll be ready. Because then you have to decide, do I want any more tests? Or should I just move forward to the next date? So here are some of your time costs. Stool culture and sensitivity, 3 days. Day 3. Today's day 1. Okay, 2 days. Ovum parasites, tomorrow morning. C. diff, 2 days. Sigmoidoscopy, I could do today at 10 o'clock. Maybe I'll give the patient an enema right in the office, or I'll do it on an unprepped sigmoid. I could do it right away. So there's that advantage. Okay? But remember, is it too invasive? Do I need it right now? Probably not. CBC, I'll have tomorrow morning. SED rate, I'll have it in an hour and a half. Electrolytes, I'll have tomorrow morning. Stool testing for occult blood, I give the patient additional cards. Someone mentioned it. I give the patient additional cards to check their stool at home. They'll bring it back in 2 days. All right? On the other hand, she tells me she has bloody diarrhea. I put a finger in. I get guaic positive stool. I don't think I need to test for occult blood. Would I lose big points? No, I'd probably lose a point. Okay, here are our results. Okay? Depending on what you chose, remember, you could move forward to that point in time. All right? Stool culture and sensitivity, negative. Ovum parasites, negative. C. diff, negative. Flexible sigmoidoscopy. Let's say you did choose to do it. And again, I would not have done it before I got back my stool culture and sensitivity and my parasites on day 2 and 3. I would not have done this. Let's say I did. And I said, go to the next test result. And remember, it was available an hour later. So I go right to my sigmoidoscopy and I get this result. Moderate erythema, edema, and friability with scattered ulcers from the anal verge to 25 centimeters. No transition to normal mucosa seen at 25 centimeters. So you say, hey, I'm a genius. I just did the test, and I get very useful information. She does have an ulcerative colitis, an ulcerating colitis. But on the other hand, do I know if it's infectious? Could infection look like this? Yes or no? Yes. Could amoebic colitis look like this? Yes. Could a bacterial colitis look like this? Yes. So on the one hand, you're proud of yourself because you ordered a diagnostic test that showed you an abnormality. But on the other hand, remember, you might be losing points because you did the test when it wasn't necessary. Could have waited. All right? And you get back your biopsy, which I tell you comes back 2 days later or 3 days later. Acute and chronic inflammation in the lamina propria, superficial mucosal ulceration with branching and distortion of the crypt architecture. Now, if you knew a lot about inflammatory bowel disease, you might know that this leans you more towards ulcerative colitis than to infection. But basically what it's telling you is there's inflammation, which I already knew basically from the history of present illness, bloody diarrhea with mucus and cramps. I know I'm going to see inflammation. Did, in fact, the sigmoidoscopy tell me anything I didn't really know? No. Did it help me distinguish on different choices on my differential diagnostic list? No. So right now I'm getting a pretty good feeling that it was the wrong thing to do. CBC, I get back the next morning, white count 10,900. She's anemic, and she has a low MCV. All right? Low-cost test tells me that there's been a fair amount of blood loss. She's iron deficient probably. She has a microcytic hypochromic anemia. SED rate, high. Serum electrolytes, potassium a little bit on the low side. BUN creatinine indicate that she might be a little bit on the dry side. Her glucose is normal. Stool testing for occult blood, again, I wouldn't have done it, but if I ordered it, I'm told it's positive. So let's say I did all these tests. What should I know at this point? Well, let's say I've done all these tests and I've gotten all my results over the next 2 days. All the stool cultures and parasites are negative. I have this sigmoidoscopy and biopsy result that is very characteristic of ulcerative colitis. My stool tests are negative. Let's say you want to be very meticulous. You do ova and parasite for 3 consecutive days. Ova and parasites times 3. Now, I'll tell you that ova and parasites come back negative for 3 days. At that point is the appropriate time to do the sigmoidoscopy. I would do it now, see this typical sigmoidoscopic findings. Now it's appropriate. My stool tests are negative. My ova and parasites are negative. My bacterial pathogens, my C. diff, all negative. I want to take a look at this mucosa. I want to see, does it have an ulcerative colitis distribution? How severe? How far does it extend? All right? At this point, a sigmoidoscopy will probably be +5. All right? And I do the sigmoidoscopy, and I see the findings consistent with ulcerative colitis. What do I do now? I think it's time to treat. All right? What's your treatment for ulcerative colitis? And again, you don't need to be gastroenterologist. You need to know first and perhaps second-line therapy. What's the treatment for ulcerative colitis? Sulfasalazine, you type it in, sulfasalazine -5. Why? Sulfa allergy, all right? Sulfasalazine, it's not a mystery. Or if you brought in the brand name, a sulfadine, -5. Allergic to that drug. Patient has, becomes acutely short of breath and has diffuse hives. The patient's roommate calls you, the patient is gasping for air, has loud audible wheezes, please exit the case. All right? I mean, that's a little extreme, but you're getting the message. So you can't give sulfasalazine. Are there any other drugs that are first line? Mesalamine, the 5-ASA component of sulfasalazine that doesn't have the sulfa component. And you write mesalamine, and you are asked route. Mesalamine, can it be given PO, orally? Yes. Can you give it rectally? Yes, you give a mesalamine enema. Could you give mesalamine IV? No, so it won't be a choice. They're not going to ask you routes of administration that are not possible. Now, in this case, frankly, you could give mesalamine by mouth, or you could give mesalamine as an enema, and either one is a reasonable first choice. Okay? I would ask you this. Would steroids be an appropriate choice at this point? Do you ever start prednisone as first-line therapy in a patient who's moderately ill like this before mesalamine with all its possible side effects? No. I'd say you lose probably at least -3 for starting prednisone without starting mesalamine first. All right? At least -3. It shows you're missing the knowledge of what is the standard first-line therapy. Okay? So at this point, unfortunately, this doesn't appear on the exam. The student should have made the diagnosis of ulcerative colitis, and you should start treatment, oral mesalamine. Enema therapy may not be sufficient because I don't know if it ends at 25 centimeters where my sigmoidoscopy ended, or if it extended up to the splenic flexure, or maybe the whole colon. Having said that, an enema is not unreasonable, all right? And I would get positive points for that as well. Remember that sulfasalazine, you would have lost points because you forgot about the sulfa allergy. So you've treated the patient with mesalamine, you wrote the prescription. What do you do next? You got those 4 buttons on top there. All right, you want to see the patient again. You give her a therapy, you want to see if it works. When do you see the patient again? Would you say a day? A little too soon. A month? Maybe a little too long with bloody diarrhea. A week, 2 weeks sounds about reasonable. Okay? So I'd like to see her in the next few weeks, and then I tell you, you see her back in 3 weeks, you move the clock to the next appointment. All right? You tell her 3 weeks. It says move the clock. It doesn't say anything. You hit the button, move clock, and either on the calendar that's on the left side of the screen, you move the mouse to indicate 2 or 3 weeks, or you can type in when you want to see the patient, 14 days from now, and then you will go there if that's what you want to do. Okay? Or you could say, call me when there's a problem. Is that what you want to do? No. You haven't ordered any other tests, so you're not going to say, call me with the next available test result. You'll say, come to see me for appropriate follow-up. When you want to see the patient, you'll indicate when you want to see the patient, move the clock. Okay? I move the clock, and now the patient's in front of you, and you're told there has been a reduction in the patient's symptoms with a reduction in the number of bowel movements to 4 to 5 per day and with less bleeding. However, the patient remains with significant urgency and tenesmus. Is the patient getting better? Yes. Do you have a good reason to doubt your original diagnosis here? Should you start doing all kinds of diagnostic tests to look for a different diagnosis? No. You're on the right track here. It's either not long enough, or maybe you need additional medication. And they tell you that there's tenesmus and urgency. Tenesmus and urgency implies inflammation of what specific part of the colon? Rectum. All right, tenesmus. That sensation of you've got to go to the bathroom, you sit down, you have essentially dry heaves of the rectum. That constant urge of needing to go, even if there's no stool there. Why is that? Because the rectum's inflamed, and the inflammation is sending signals from the rectum to your brain, something's going on here, I'm irritated, let's go and empty. And you sit down and there's nothing to come out. That's a specific symptom of rectal inflammation. Is it specific for ulcerative colitis? No. If I have CMV proctitis because I'm HIV infected, I have the exact same symptoms. If I have Shigella colitis and my rectum is highly involved, I'll have that symptom. It just tells me that there is an area specifically in the rectum that is still inflamed. So what would I do now? I already had the patient on oral mesalamine. What's reasonable to do now? Add a medication in topical form. And I would add mesalamine as an enema. Or I might add steroid as an enema. Remember, I'm not going to give patients steroids by mouth because it has lots of systemic side effects. And the patient's not that sick. At this point, it would be appropriate to choose a second-line therapy, such as a mesalamine enema, or cortisone enema, or cortisone suppository. Or maybe, if the patient's not too sick, say, you know what? It's just a week has gone by. Let me see the patient a week later. Maybe the medication just takes more time to work. I would probably get no loss of points for that either. Now, if the patient comes back and said, you know what? Your medication, I feel a little bit better, but I'm seeing more and more blood on the other hand. Would I want to see the patient back in a week without changing therapy? No. If the patient's deteriorating, it's a clue I probably have to add something. If the patient's getting better, I might want to see how the patient does with the same medication, just giving it a little bit more time to work. Okay? So what would I do now? Well, I would pick topical therapy. I'd write mesalamine. How do I give it? PO or rectal. At this point, I would say rectal administration. Or I might give the patient some kind of local treatment with a steroid. Again, not systemic steroids. All right? If you picked a flexible sigmoidoscopy here, you might pick up a point. Do you need a sigmoidoscopy if you sigmoidoscoped the patient 2 weeks ago? Not really. The patient can tell you based on her symptoms how she's doing. If you did a sigmoidoscopy to see how inflamed it remained, I don't think you'd lose much. Maybe you'd pick up a point because you're trying to document objectively how inflamed things are. Maybe if things are very hot in there, maybe if the endoscopic picture got worse, maybe I would add steroids. All right? This is one of those areas that there are multiple ways to handle the patient. You're not going to lose points here for getting a sigmoidoscopy. You're not going to gain tremendous points for getting a sigmoidoscopy. All right? Patient, you do this for the patient. Let's say you give the patient mesalamine enemas or cortisone suppositories. What do you do next? You've ordered it. Order is given. What do you do next? Follow up again. Again, about how long? I'd say 1 week, 2 weeks, 3 weeks at most. I wouldn't wait a month or two. I'd lose points for that. I'm sending home a patient who's still symptomatic and I'm waiting too long a time. 1 to 3 weeks. Patient comes back. Again, I have to move the clock. 2, next appointment. All right? Next appointment, patient arrives. I'm given the following information. The patient returns and reports that her symptoms have improved entirely and she is having 2 foreign bowel movements per day without bleeding. All right? What do I want to do now? Wouldn't I like to see the patient one more time, make sure she's still well? Yeah, I'll say come back in 2 weeks. This time you're doing well, maybe 4 weeks. All right? Come back in 4 weeks. The interval history is now, patient remains entirely asymptomatic, is tolerating the meds well. What do you do now? At this point, I think it's appropriate to exit the case. Is there anything else? Is there any counseling I should do for the patient? She's practicing safe sex. She's not overweight. Are there dietary precautions for ulcerative colitis? Not really. Does she have to wear a seatbelt? No. I mean, it's nice, but I'm going to get points for that? Not really. All right? So at this point, I'm going to say I want to see you in 4 weeks. 4 weeks, she comes back. She's well. I'll say exit the case. Anything else I want to do? Not really. Final diagnosis, ulcerative colitis. You scored a full 10 points on this. Okay? Any additional orders? If I get this prompt, anything else I want to order for this patient? No. I'm going to continue the current medications, and we'll see you again in about 4 weeks. And I type in my diagnosis, ulcerative colitis. All right? We've just taken you through painlessly a typical case.